Good morning, all of you, and thank you, Mrinal and Venugopal, for giving me the opportunity. At the outset, I have a disclaimer. As all of you know, that the topic of disability evaluation is very vast and it is changing. There have been revisions of the guidelines, and the most recent guidelines which have been released were in middle of March this year itself. So there will be many areas which I will not be able to cover in detail. Why it is important to know about disability evaluation, and very importantly about locomotor disability evaluation. We are all either learning or practicing physical medicine and rehabilitation, and over the years it has been realized that considering the nature of our specialty, the contributions that we can make, we should be the most sought after person as far as the locomotor disability evaluation is concerned. The government also realized this, and since the beginning of disability assessment guidelines, they involved PMR experts in the framing of the guidelines, in the revision of the guidelines. And I'm very happy to share that AIIMS New Delhi Department of PMR has always been playing a very important role in the revision of the guidelines and framing of the guidelines. And this was the case this time also in the latest guidelines. So I will like to structure the presentation by this brief introduction, and the current guidelines are also going through some further revisions because it is a work in progress, it is an ongoing process. The first training program with the revised guidelines was held at AIIMS New Delhi in April 2024, and there were about 80 participants from different institutions, and they had given their feedback, and after that 3 more training programs have been held. And as a result of feedback by the participants in these 4 training programs, there is a need which is felt that this latest guideline also needs some corrections and amendments. The latest guideline, I have my own reservations about that because it has been made so bulky and voluminous, 867 pages, including Hindi and English version. So you can practically say that it is 400 plus pages of each language. And this is not convenient to carry anywhere. My experience has been that the disability evaluation guidelines are very useful if you keep the hard copy in your OPD or in the clinics or in the ward also, so that it is handy. You cannot remember the percentage of disability for different clinical conditions. Even if you ask me what is the percentage of disability for a transtibial amputation, I will not be able to tell you immediately. There is no need to remember everything when there are ready documents. So carry the documents, keep the documents where these are required. And the other thing is that one of the basic flaws which I have been pressing upon the government repeatedly is that disability is an experience of the whole individual. It is not an experience of a part of the body or a limb. So please move in the direction of reflecting disability assessment in relation to the whole person. They are till date resistant, but I am not giving up. The other thing is that we are not learning from the advanced countries or the countries where more objective guidelines are being followed. See, disability is a universal problem. Disability assessment is required all over the world for various benefits and schemes and concessions, and even for research purpose. You want to intervene or you want to try a new intervention, you want to see before the intervention what was the extent of disability and whether the intervention has reduced the extent of disability or not to prove its effectiveness. So practice is very important. PMR people should be actively involved in disability evaluation certification. And one thing more, this time I have been able to do, PMR role and responsibility does not remain confined to locomotor disability only. I have been able to put importance of PMR as a member of the disability board in many other conditions also, and they have accepted it. And some of those are multiple disability, if locomotor disability is one of the components. The other is blood disorders. The next is chronic neurological conditions. So in all these conditions, if the board is constituted according to the guidelines, PMR person is more likely to be a member of that group. So make use of this opportunity. Now, as I was telling you that it is a very voluminous document, but if you carry the printout of the English language version of the portion of the guidelines where your role is important. So these are the pages that I have numbered here. It is not intimidating. You can easily carry this. And of course, you can always carry the full version in the soft copy format. So pages 456 to 482, these are the main pages which have the content related to various conditions that we come across day in, day out in clinics. Then page number 497 to 502 are the pages where chronic neurological conditions are mentioned, and we have a role to play in that. Although this time the neurologists were trying to dominate those guidelines, and as a result of that they have created confusion, and the ministry also did not realize they have done copy paste from our contribution and added the contribution given by the neurologist. So as a result of that, you will see discrepancies in the document, and they realize it now. They are going to do the amendments. Page number 502 to 520, blood disorders. There also it is clearly mentioned who will be the members of the board, and PMR experts are mentioned in black and white. Then page 520 to 523 deals with multiple disabilities. We have a role to play in that. Then there are appendices 1, 2 and 3 which in locomotor disability section we have to regularly refer to. Appendix 1 deals with the MRC scale, manual muscle strength testing criteria. Then there are scales form 1 and form 2. Then there is an appendix which gives what is the normal range of motion at a joint, so that there is a reference point against which you can compare the range of motion available on examination that you detect in a particular case, because there is a percentage of disability to be assigned to loss of range of motion. Then there are different sections in the guidelines. Each of these sections deals with individual condition. Section A deals with the guidelines for assessment of permanent physical impairments in individuals having involvement of the extremities, upper and lower extremities. This is a significant portion of the guidelines. This is where we deal with the restriction of range of motion, diminution of muscle strength, various other issues such as shortening of the limb, etc. Associated problems, whether the deformity is in non-functional position or in functional position, whether there is pain or not, and if there is pain, what is the severity of pain. So according to that, certain percentage of disability is assigned. Then spine is an important section. Amputation is section C. Clubfoot and a few other conditions such as Charcot's joint, etc. These are D. Chronic neurological conditions E. Spinal cord injury is very important for us. We regularly come across people either as inpatients or as outpatients. Then acid attack victims, cerebral palsy, leprosy cured persons, short statures or dwarfism, and muscular dystrophy. So these are from A to K different sections which deal with these conditions. And this is the cover page of the guidelines as they were notified through the Gazette of India document. Now, what is important is that locomotor disability is one of the first disabilities mentioned, and rightly so, because if you look at the population at large, prevalence wise, locomotor disability is the most prevalent type of disability in society. And then there are further sections. You may not be able to read very clearly, but the purpose is not to teach everything that is in the document. What I want to emphasize is that all the junior residents who are pursuing postgraduate programs, either at MD level or at DNB level, they must read it. They must read it again and again, because every time you read, you realize something new in the existing guidelines. It is like when you pick up any standard textbook of medicine, Harrison or any other, every time you open the same chapter, but you will see many new things, whether it is fever or pain or dyspnea, whatever. So read it again and again. Every time you will see something new, and whenever you come across cases which are not very straightforward, because most of the times in the clinic for disability assessment, you don't get a standard textbook case. There will be complications, there will be deformities, there will be associated problems. So you have to be aware and read again and again that I came across this particular person, although it was a simple transtibial amputation, but he had along with amputation these other things also. So many a times in locomotor disability also the person may have scoliosis as well as amputation. So how to assign a percentage of disability which is computed finally, this is important. So section A, as I told you, these are the guidelines for evaluation of permanent physical impairment of extremities, upper and lower extremity. In the beginning it is upper extremity followed by lower extremity, but what is important to remember is that the extent of disability never exceeds 100%. No matter which formula you apply, it will not exceed. Second important point to remember is that disability is to be expressed as a whole number, not as a fraction of a number. And always mention in relation to which part of the body, till we have the whole body concept incorporated in the official guidelines. Many a times PMR experts are requested to appear in various courts of laws, and most commonly in the motor vehicle accident claim tribunal cases. And the honorable judge may ask that this person has been issued a certificate mentioning 45% disability in relation to left lower limb. But if we have to grant a compensation amount, we need to know what is the disability percentage in relation to the whole body. So please tell us what is the disability in relation to whole body. The honorable judge often and invariably asks this question. Then I want to know the experience of the audience here. What do you answer or what should you answer? Because I know what I answer, but I want to know. This is a day-to-day issue. The honorable judge will have a different opinion because they follow different guidelines and documents while awarding compensation to an accident victim. Insurance company is asked to pay that much amount. Silence is not the answer. I want some interaction. I have not come here to teach. You are all learned people, intelligent people, educated people. Okay. So there are many slides. I am not going to burden all those on you. But as I move forward in the presentation, you can always refer. The document and the guidelines are in public domain. It is not a very secret document. You can easily access. Go to the Department of Empowerment of Persons with Disabilities website. The whole document is there, free to download. So there are many tables where we do the calculation and finally come to the computation. In recent years, the importance of disability assessment has become even more. In media, you may have seen people are appearing in NEET exams, NEET UG or NEET PG exams, civil services entrance exams, and there are categories of persons with disabilities who are candidates who are competing, and they need to produce a certificate, proper valid certificate. And many a times, these certificates are found to be faulty. All over India, people are getting certificates. So whenever there is a situation that comes to our notice, the Department of Personnel and Training may refer the cases to us that these are the 7 candidates who have cleared the theory exam and they are candidates with disabilities. So there is a medical board to be constituted at AIIMS or any other hospital, whether it is Dr. Ramanohar Lohia Hospital or Safdarjung Hospital. They want to verify the certificate which the candidate is carrying is genuine or there is some error or some suspicion in that. Because the benefits that accrue are generally lifelong. So PMR experts have to know the guidelines thoroughly, and many times in certain challenging situations also, what will be your answer to such situations? Because we are in the government system to help the government and its institutions and various bodies. Similarly, there are candidates with disabilities who want to become doctors through the NEET entrance exams, or those who have already become doctors, they want to become specialists in various fields. So there are separate medical boards because there is 5% reservation in higher educational institutions for persons with disabilities and 4% reservation in jobs for persons with disability. And for all these things, the genesis is always from a valid disability certificate issued from a duly notified medical board. So your role is very important and you can perform your role very well in the years to come. If you are aware of various sections and subsections in the, this is what I was referring to, appendix 3, which is normal range of motion at different joints. It is handy. I cannot remember what is the normal range of motion at the knee joint. You can refer so that there is no error at your end, no mistake. Then there are certain formulae to be applied in these guidelines for locomotor disability. I just want to know, the timer indicates what is the time that remains. I think that is the case. 14 minutes remain. Okay. So there are certain prehensions, types of prehensions based upon how much is the loss of prevention. There are certain percentage of disability, because hand is one of the most important portions of the body as far as the upper extremities are concerned. It is very versatile, very important. And in the previous guidelines, there used to be 4% additional weightage for the dominant upper extremity involvement. In the guidelines that we framed way back in 2001, I enhanced this based upon the consultation with experts to 10% additional weightage instead of 4, because that was a little, it was felt that it was a better reflection of the significance of the dominant upper extremity in those people who have acquired conditions as the cause of the disability. For many other things, we are still following the standard recommendations that were the outcome of the national level seminar at AIIMS New Delhi, when Dr. S.K. Verma sir was heading the department of PMR at AIIMS New Delhi, and Dr. B.P. Yadav sir was head of the department at Safdarjung Hospital. And these guidelines have so far stood the test of time, with some modifications and addition of certain conditions, etc. Like when I got the chance to chair the locomotor disability, I added a few conditions. This includes lymphedema, this includes club foot, this includes Charcot joints, etc., and spinal cord injury, because these were not mentioned by specific diagnosis in the previous guidelines, and the government accepted it. There is a debatable issue that many times what happens is that there is no mention of people who have undergone joint replacement. Locomotor disability group, people have undergone hip replacement, knee replacement, or any other joint replacement. What percentage of disability to be assigned to that? So it is still being debated. Maybe in the years to come, there will be a separate section devoted to those conditions also. The other debatable condition is that there are many people with locomotor disability who use assistive products and devices. So in case of visual disability, we consider the disability best possible visual correction with the aid to improve the vision. In locomotor disability, there is no mention of that. So these are the areas in which there will be clarity in the next revision of the guidelines in the years to come. I'm just sharing with you these things so that some of you may come up with some proposals and help the government. In the locomotor disability, there is one particular important portion which has additional weightage for different types of disabilities or conditions. For example, if there is a deformity in non-functional position, then 6% additional weightage is given, whatever is calculated based upon the reduced muscle strength or range of motion, etc. If it is in functional position, then 3% additional. Pain is an important contributor to disability, but there are no universally accepted guidelines for assessment of severity of pain and thereby assigning a percentage of disability. But right from the beginning, pain has been given some additional weightage since 1985-86 onwards. So for mild pain, we have assigned 3%. Mild is something which is slightly interfering with function. Moderate, interfering with function, definitely 6%. And severe, grossly interfering. Now you can argue that these are still very generic words in English language, and there are needs for making it more objective. Loss of sensation, partial loss up to 6%. It is not necessary that everybody who has a partial loss of sensation has to be assigned 6% additional weightage. And similarly, superficial complication, 3% can be assigned, deep complication, 6%. So total percentage of disability in spite of additional weightages will not exceed 100%. And this is the formula that I am referring to, A plus B 90 minus A divided by 90. This is known as the combining formula. A is the higher value and B is the lower value. And in the disability assessment scenario, there are many situations where there are two different types of or two different areas of involvement or two different types of disabilities. Now, this is very commonly used in multiple disability conditions. Earlier, the same formula was being used for multiple disability. For example, somebody has locomotor disability and the same person has visual disability also. So what will be the final percentage of disability assigned to that individual? So you calculate as per the guidelines what is the component of the locomotor disability, what is the visual disability. If locomotor is higher percentage, that becomes A. If visual is lower, that becomes B. And then you apply this formula and come to a final percentage of disability. So, but this time in the 2024 revision, their experts in the other groups of disabilities, they insisted that we want to have the A plus B 100 minus A divided by 100 formula. Ideally, there was no need for that because the calculations can still be satisfactorily done. But what is happening is that there are certain groups which have tried to hijack the disability evaluation area. Because PMR people are very complacent, I am very sorry to say. People may not like my utterance, but they are not taking much interest in disability assessment. And that is why the space that we are vacating is being occupied by other experts. And therapists are also agitating, why are we not involved in disability assessment and certifications? So these are warning bells. So they insisted, and the administration in the Department of Empowerment of Persons with Disabilities was easily convinced by them because they themselves have never read the earlier guidelines. So I don't want to create another controversy here, but I am not happy with the current scenario. Earlier, Health Ministry used to play a more active role in framing of the guidelines of disability assessment and dissemination. Over the last 10 to 15 years, the Directorate General of Health Services has taken less interest in these areas, and as a result of that, the Department of Empowerment of Persons with Disabilities is becoming more and more active because they also have to show their contributions and all. Nothing wrong with that. But what would have been better is better coordination between the health and the Department of Empowerment of Persons with Disabilities, which unfortunately at present is lacking. So that is why if you read the guidelines carefully, you will be shocked. One particular group of experts in a particular disability area, they have inserted one voluminous document entirely, and in that there are paragraphs, the social condition of the individual, the education of the individual and all, which have nothing to do with the final computation of percentage of disability. But they wanted their presence to be felt. पूरा document इतना voluminous बना दिया, it becomes unmanageable. And when we point it out, the attitude of the bureaucrats is, नहीं सर बहुत ज़्यादा हल्ला कर रहे थे, we had to pacify them, so हमने कहा चलो हम डाल देते हैं. These are not the ways in which concerned departments and ministries function. They should have the skill to convince them that for the last many years these things have been happening and they have been happening very well. By adding this, you are making the document so bulky and unwieldy and nobody can carry or nobody can read it. But they want, because I'm not hesitating in mentioning, there is a group of experts at AIIMS New Delhi who are very aggressive and agitating. And they had developed a particular modification of a particular scale and they insist कि हमारा AIIMS के नाम वाला scale डलना चाहिए इसमें. Clinical Epidemiology Network. But that was, some experts who know the disability scenario, they were not happy with that. But करा लिया उन्होंने अपना, by very pushy group of people. So what I am trying to say is that there are many areas, if we don't guard our territory, people will push us out of the arena and then re-entry will be very difficult. Again, extra points are there for shortening of the limb. For example, if there is shortening, then first half an inch there is no additional weightage. For every half an inch beyond that, there is 4% additional weightage. This is about the shortening of the lower limb. In the upper limb also there can be leg length or arm length discrepancy. For that, for the first 1 inch there is no weightage, and for every subsequent 1 inch difference there is 4% weightage. Basically, I want to have some time for interaction or any questions. Otherwise, if I keep speaking, the topic is so vast, the document is so bulky. There are certain areas in the document which deal with the deformities of the spine, kyphosis, scoliosis and all. And you should know that Cobb's angle is the recommended angle to follow. In the chest expansion, this is also something which I insisted on adding so that there is more objectivity. And counting in a single breath, this has given some more narrow ranges instead of very wide ranges in the previous guidelines that were there. I want to basically coming towards the end. Amputation is important condition. Here, if you see carefully, upper extremity, earlier guidelines did not mention about Krukenberg amputation or operation. So this time I inserted that particular thing because in India still some people have undergone Krukenberg kind of operation. And if they need a disability certificate, there has to be some mention. Otherwise, in the court of law, it becomes a debatable point. कि आपकी guidelines में तो कहीं लिखा नहीं है. So that means you are being very arbitrary. So in order to avoid that kind of allegation on us, I thought it is better to put it down. And there is nobody standing up to contest that. Similarly, there is one place where I have in the amendment added one condition. See, the lower limb amputation we commonly come across, there was one level which was missing earlier. This time I have added one. It will be notified soon. Congenital amputation, again one has to be very careful that if it is the congenital condition, you don't add 10% for the upper extremity involvement. That addition of 10% is for the dominant upper extremity involvement only in acquired condition. This very important formula, it keeps recurring in the entire document at many places, and you have to be very comfortable in the use of this formula. These are the three appendices only, locomotor. Nothing is very complex in this thing. The problem is that still there is an element of arbitrariness in these guidelines, because these percentage of disabilities don't match the functional performance assessment of the individual. That is a major drawback. And second major drawback is this is not reflected in relation to the whole person. So as a result of this, what is happening is that a person with single lower limb involvement due to polio is having 45% disability. But another person with involvement of both lower limbs, not severe involvement, but may have 35% of disability as per the current criteria. So unless we pay attention to in how much part of the body, this becomes again a flawed set of guidelines. In real day-to-day scenario, the person with bilateral lower limb involvement is at a far greater disadvantage in general, if there are no extremes of involvement in terms of muscle strength and all. And in addition to that, if there is an additional limb involvement, then the person becomes more involved and affected. So if we move by a single step intervention that let us reflect in relation to the whole body, this is what the Americans do, this is what the Western Europeans do. Some Asian countries also do the same thing. They reflect the disability in relation to the whole body. And the apprehension in the mind of the secretaries in the ministry is that at present, if you have given 50% disability in relation to that left lower limb to the polio affected individual, and if we convert it in relation to the whole person, it will become almost 30% or so. So that person will be deprived of the benefit because उसकी 40% से कम हो गई, तो वो हमारे दफ्तर के बाहर लाल झंडे लेके खड़ा हो जाएगा. What I try to tell them is that this 40% is also arbitrary. So why are you insisting with it? Benchmark disability, they have given a new term in the Gazette. Oh, I am at a loss, मेरे बस का नहीं है. And finally, I am thankful to the people who supported me in various deliberations and framing of the guidelines. And Dr. Ritu Majumdar is there, and Dr. Vidya Thani sir was there to guide us, and Dr. Suman Badal was the member secretary, and besides them, there were many other people. So, Thank you so much. If there is any question and if time permits, the document as such is very voluminous. I cannot cover entire thing. You are not students and I am not a teacher. But it is important. We should not lose this territory to show our importance and to make a significant contribution. कल को कोई भी केस आता है dispute disability related, the first expert which should come to the mind of the policy planners is PMR expert. लेकिन धीरे धीरे आप सिर्फ सीरिंज और नीडल लेके ही घूमते रहोगे कि यहाँ पर PRP इंजेक्ट कर दिया, इधर हाइड्रोकॉर्टिसोन इंजेक्ट कर दिया. People will not bother much about you 10 years from now. Thank you.
Thank you very much for the work you're doing. I think it's really important that you've taken the lead in doing that. And I completely agree that when it comes to the matters of disability, PMR should be in the forefront. Number two, I just have a question. My understanding now is that medical boards to evaluate disability are entirely made up of government medical officers. Is that right or is that wrong?
That was the situation till a few months ago. But in order to clear the backlog, the Department of Empowerment this time officially decided that a private practitioner can also be a member of the board, but the chairman will be a government doctor only.
Okay, but the board will always be in a government institution.
So far, yes.
Okay.
But the government institutions are also now spreading out instead of being concentrated in the cities or the centers. Now there is delegation of the power to make disability certificates to the districts, hospitals and beyond the districts also. So that the waiting period is cut short. But again, this is where the problem is coming. People are not very rigid or strict and they have not been well trained. The department has started the training program, and in the beginning 4 training programs which have been done, these have been at the newly created AIMS. Gradually they will involve many other institutions also, because it is a training which will clarify many doubts and it will reduce the chances of forgery or wrong assessment. Because as per the ministry's own data, more than 85 lakh UDID cards have been issued to persons with disabilities. And when they randomly check it, they feel that 1 out of the 4 or 1 out of 5 is wrong. And this kind of problem is more in conditions which are special or specific learning disabilities or hearing disabilities, because it is easy for the candidate to exaggerate the symptoms and get the benefit.
Thank you.
Thank you.
I've been in the disability board and it's confusing and difficult. But however, what I have understood is we cannot actually put mathematics on human beings. So there will always be a mismatch and confusion. And that is why we experts are necessary, and we are the only person who keep examining patients regularly to bring this guidelines to a certain amount of justice to the people who are disabled. So please think it as that, not as a pure mathematics of 1 plus 1 is equal to 2. What I understand from the A plus 90 minus AB, it's actually logarithmic curve, which takes it never to 100, but towards 100 only. So as you add disabilities, it continues as a logarithmic curve. So your aim should be to give a fairness to your evaluation, and you bring it into the guidelines that the government has given, so that controversies are far less. The other thing I have a doubt about was, and about the 100% and the 90%, what my understanding is, the McBride actually gives 100%, and we evaluate from 90%, and the add-on 10% is from the additional deformity. So when so we have corrected it to multiple disabilities as 100%, previously it was 90%, so I think that's far better now. Regarding the shortening, I have a suggestion and a doubt, because shortening, if it's a long person, then it is it finally comes to be more than an amputee. When you calculate it, if he's got a significant shortening.
True.
So my suggestion is, I don't know whether it's right, but if we can put it at, let's say, 1/3 of the leg, more than 1/3 of the leg is shortened, then take the disability in terms of the amputation chart. So then there will be more fairness.
You can give in writing this suggestion. I mean,
Yeah,
I
no,
will
yeah, sure.
There is another trend also which is emerging. The ministry is seriously thinking that if a person has 60% locomotor disability and 5% hearing disability, should the benefit of multiple disability be given or not at all? They are thinking that unless the other type of disability is 20% or 25% or 15%, we should ignore that. I am not in agreement with ignoring any type of disability, but what is happening is that there are many candidates who are aspiring for civil services. And somebody deliberately created another type of disability to qualify for multiple disability category. He had initially one type of disability. So he tied his knee joint for several weeks, so the contracture developed in the knee joint. And he had 10% additional weightage and locomotor plus another type of disability which he had originally. So, because the number of candidates who are competing in the multiple disability category for civil services is much less than the candidates who are competing in a single disability category. Till date, in 35 years of my rehab experience, I am yet to see any parent who comes to me, Doctor साहब मेरे बच्चे की disability दूर कर दो. But I have seen many कि इसकी 40% या उससे ज़्यादा कर दो. This is a very depressing scenario. One candidate was issued a disability certificate from our department, 22% disability, locomotor, as per the guidelines, and he started arguing and fighting. I told him the guidelines हैं, आप तो पढ़े लिखे हो, आप देख लो, इसमें कोई स्कोप ही नहीं है. नहीं मेरा 40% से कम में तो काम नहीं चलेगा, and this and then आप देखिए कुछ कोई consideration हो, कुछ ले दे के हो जाए and all those things. He said, I politely turned it down. We don't do these things. Then he went to another hospital within Delhi, and next week in my OPD he came and showed me the disability with 40% disability. And I asked him कि guideline तो same है all over India होनी चाहिए. नहीं साहब मेरे 25,000 रुपए लगे और मैंने बनवा लिया. So I have this is very sad state of affairs. People get forged certificates, and now some are coming to the highlight. Wrong OBC certificates, wrong caste certificates, and disability certificates which are wrong is another category.
Sure. My suggestion is you have to be both the police and a doctor at the same time when you are sitting in the disability.
Yes.
Okay, I'm from Vellore. To be very frank, we hardly give any disability certificates because just about 3 kilometers from my institution, we have the government Vellore Medical College where most of the certificates are given. We have a problem. I'm sure there are postgraduates who work in the government setup here and the non-government setup. And I'm sure the postgraduates who work in the government setup are learning this better than the persons who are not. My problem is, like last week also I got a summons. We do get patients from outside Tamil Nadu quite a lot, as you may know. We give a discharge summary after they have rehabilitated and gone. And after a few years, we get a summons that this person has got, like for example, this is a spinal cord injury, T4 complete, last week what I got. And somebody has given in the local hospital, probably in West Bengal, 100% disability. Now the court sends summons to me because I am the last documented treating doctor. So how do I approach this? I mean, I can't say to the court, I'm not coming, I didn't give this certificate. We have to send some letters up and down, and you know, it's little far off. It's like a logistical and stressful problem where, because he got discharged from me last, from Mumbai, from West Bengal, from Assam, we kept getting summons. So what is my rights, or how can I process this?
So my answer will be slightly different, but I have seen Professor Suranjan in a position to guide in this. Sir, we would like to listen to you also.
I ask for the patient to be brought to the court, and just before giving evidence, I actually re-examine and confirm that the disability is the same. It's difficult to get them to come here, but anyway, if I have to go to Assam to the court, but I suppose now with video conferencing, that may not work. In the old days, that worked. But I think you're within your rights to re-examine the patient and give an opinion. The courts, I think, will honor that.
A group of 3 ENT experts in Mumbai who do coaching of candidates who are trying to claim benefits for the hearing deficits. So these things are also, because this is giving career opportunity to some other kind of experts also. कि आपने कैसे टेस्ट ऑडियोमेट्री टेस्ट कैसे फज करना है वो हम आपको सिखाएंगे.
Yeah, so one suggestion I had, Sanjay, is that we should officially run courses and certify even PMR doctors and have a recertification every 5 years so that you're up to date. If we do that, I think even if you've, there'll be more strength in what we're doing. So like in many other certifications, I feel IAPMR should officially run a course. It could be 1 week, 5 days, whatever is the length. And all those who are keen to be certified should undergo that course, be assessed, get a certification valid for 5 years, and then revalidation. That will encourage other groups also to follow in the same way. And then I think some more sanity, shall I say, will come to this entire process.